Good morning. Today we will discuss Ménière's disease. We will review its diagnosis and management based on current guidelines. Diagnosis of Ménière's disease. The diagnosis of Ménière's disease is clinical. The American Academy of Otolaryngology and Head and Neck Surgery provides diagnostic criteria. A patient must have at least 2 spontaneous episodes of vertigo, each lasting between 20 minutes and 12 hours. These episodes are accompanied by fluctuating or non-fluctuating sensorineural hearing loss, tinnitus, or a feeling of aural fullness. It is important to rule out other disorders that could explain these symptoms. Audiometric testing is an essential part of the diagnostic process. An audiogram is used to confirm the presence of sensorineural hearing loss, which supports the diagnosis. However, other tests, such as vestibular function tests and electrocochleography, are not routinely recommended for diagnosis. Magnetic resonance imaging, or MRI, of the internal auditory canal and posterior fossa may be considered if there is asymmetric sensorineural hearing loss confirmed by audiometry. This imaging is not a mandatory part of the diagnostic workup for all patients. It is also important to consider and assess for vestibular migraine, as its symptoms can mimic Ménière's disease. Management of Ménière's disease. Patient education is the initial step in management. Patients should be informed about the unpredictable nature of the disease, the potential for fluctuating symptoms, and available treatment options. Lifestyle and dietary modifications are often recommended, although evidence is limited. These include reducing sodium, caffeine, and alcohol intake. Managing allergies and minimizing stress are also suggested. For symptomatic management of acute vertigo attacks, a limited course of vestibular suppressants may be used. These medications are not recommended for long-term use. For maintenance therapy, diuretics or beta-histine may be offered to reduce symptoms or prevent attacks. The evidence for these interventions is limited, and they are considered options rather than strong recommendations. For patients who do not respond to non-invasive treatment, intratympanic steroid therapy may be considered, or a referral to a specialist is appropriate.